talking about panoramic imaging today. In dental radiology, we have the most commonly used two-dimensional imaging being your IUPAR, that is your intraoral periapical radiograph, and panoramic imaging. So today we'll be seeing in detail about the panoramic imaging. How is it taken? What is the principle? What are the indications? What is the technique? Advantages, disadvantages, what are the landmarks that can be seen, and the common errors we come across when we take a panoramic imaging. So what is panoramic radiography? It is otherwise known as panoramography or rotational radiography. It is a radiographic procedure that produces a single tomographic image of the facial structures, including both their maxillary and mandibular arches and their supported structures. So panoramic imaging, it is a curvilinear variant of your conventional tomography. So basically in a single X-ray, you're going to visualize the maxilla, mandible and the associated structures. So what is the advantage of this panoramic radiography over your conventional intraoral periapical radiographs? It has a greater ease of the technique and less time taken to produce panoramic radiographs. In addition, there's an advantage of visualization of the areas of body of the mandible, ramus, TM joints, and maxillary sinus. So this entire structure can be seen, it can be evaluated, and both the right and left sides can be compared as well. So this is a picture of your panoramic imaging where you can see your entire maxilla, mandible with the dentition and the associated structures such as your TMJ, your antrum, and your entire body is being visualized. So coming to the history of radiography, we know in 1895, Sir William Conrad Roentgen has discovered X-rays. Then in dental radiography was first discovered by Otto Walkhoff, and in 1933 Dr. H. Numeta of Japan has proposed this rotational panoramic radiography, and the panoramic radiograph that we use, that is slit beam method, it was proposed by Dr. Y.B. Patiru in 1946. So what are the different generations of OPG machines? It is OPG 3, 5, OPG 10, and then the DXIS, that is the worldwide first digital panoramic system which came into effect that we use now. When it was conventional technique, the panoramic radiograph used films where we develop it in the same way as our conventional IUPARs. But now it is being replaced by digital receptors and we get to view the digital images. So coming to the clinical indications of panoramic image, why do we have to take a panoramic image? So it helps in the overall evaluation of your dentition. It is used as a substitute for full mouth intraoral periapical radiographs, reducing patient exposure, of course. For evaluation of tooth development for children, the mixed dentition and in age, in periodontic patients, we can visualize the permanent teeth, primary teeth, and the state of your developing tooth bud as well. To assist and assess the patients during orthodontic treatment and the evaluation of post-orthodontic treatment, to establish the site, extension, and size of lesions such as cysts, tumors, and development anomalies in the body and rami of the mandible. So, of course, we can visualize the extent a lesion is covered in our maxilla or mandible, evaluation of the position of an impacted tooth, detection of maxillofacial trauma, for the follow-up treatment, progress of pathology or post-operative bony healing, of course, after a surgery or after treatment, we can do a follow-up evaluation with the help of panoramic imaging for the evaluation of your TMJ and TMJ disorders, study of your antrum, that is your maxillary sinus, any pathologies associated with the maxillary sinus, the evaluation, periodontal evaluation of the tooth and the alveolar bone levels. In case of any bone disease, we can evaluate the maxilla and the mandible, evaluation of developmental anomalies, and lastly, the vertical height of alveolar bone in case you're going to place a dental implant. So this particular radiograph plays a role in almost all the areas of dentistry. So what is the principle of panoramic image formation? So we'll just simplify the principle of panoramic radiograph. So imagine an assembly containing a disk with upright physical objects represented by the letters and the collimator. So I'll just show the picture. You can see a disk. You can see that there will be two adjacent disks. One will be rotating in clockwise direction and the other will be in anti-clockwise direction. And you have the object being placed upright, and you have two collimators, one near the X-ray source, which causes your beam to become a narrow one, and you have a collimator near your receptor, which prevents the scattered radiation from the object. So what happens is the first disk, it rotates in the clockwise direction in the same direction as that of your beam, and the second one will rotate in the opposite direction as that of your X-ray beam. So what happens is the disk, objects that is there in the disk which is rotating in the same direction as that of your X-ray beam, they'll be seen clearly in your radiograph, whereas the other area, that is DEF, which is in the opposite direction, it will be blurred. So we'll come to the explanation. In this conceptual view, the X-ray source and the collimator are held stationary. The receptor moves through the beam and the rotating disc also carries the object A to F through the beam. Object A to C moves through the beam at the same rate and direction as that of the image receptors. They'll be imaged well. And the object D at D to F move through the beam at the same rate as that of the receptor, but it is in the opposite direction. Those images will be blurred. So this is a replacement of the picture that we have seen with our jaws and the teeth. So where A to F will be representing the teeth and the associated structures. Same principle holds whichever area that is being rotating in the same direction as that of the receptor or the beam will be recorded with accuracy, and the other one which is moving in the opposite direction will be recorded blurred, or it can be blurred beyond recognition as well. So what is meant by focal trough? This is an important term which is being considered when we are talking about the image that is being formed. The image layer is a three-dimensional curved zone or focal trough where the structures lying within the layer are reasonably well defined or in a final panoramic image. The structures seen on the panoramic image are primarily those located within the image layer. And the objects outside the image layer is blurred, magnified, reduced in size, and sometimes distorted. So it will be better to explain with a picture. So this is our zone where this is our focal trough where the objects that is lying within this darker zone will be recorded with accuracy, and the one which is located outside will be blurred. So the image layer thickness, that is this particular thickness, it depends upon the effective projection radius and width of the beam. The closer the rotation center of the teeth, narrower will be the focal trough. In most of the machines, the focal trough is narrow in the anterior region and it is wide in the posterior region. So this picture represents it is closer to the center of the trough, that is the darker zone. Anatomical structure is positioned, the more clearly the image is formed on the resultant radiograph. So in this particular zone, you will get a very clear image of what is being recorded. So this is different centers of rotation. So first, this picture is representing double center of rotation. One of the right and one for the left side of the jaw. This particular image is showing triple centers for location, which is marked by X1, X2, and X3. And this is C is a moving center of rotation where this machine rotates continuously, moving across, and it is similar to the arches that is creating an uninterrupted images of the jaw. So in B and C, you get a continuous image formation. So coming to the machine, how is the machine looking in panoramic radiograph? High quality film based and digital panoramic machines produce standard panoramic images of the jaw, having a capability of adjusting to the patient of various sizes, making the frontal and lateral images of the TMJ as well. So we'll just explain what are the components of this panoramic unit. You have an X-ray tube head here. You'll have a head positioner. So basically, we will position the patient over here. We'll see a picture in the next slide. And along with that, we can take our cephalometric radiographs as well in this particular area. So in case it was a conventional, we had our intensifying screens and cassette, but now it is digital. So this is a machine basically. So this is how we position the patient. So this is the area where we can move the machine up and down. That is the control panel. And we position the patient here, and this will be your X-ray source and the receptor, which will be rotating around the patient at the same time to produce a image. So we'll just see the X-ray parts in detail. First one is your X-ray tube head. This is similar to that of the intraoral machine, except that the collimator used is a lead plate with a slit, and the X-ray beam thus emerges through the collimator as a narrow band. So we have seen in the principle already, the collimator is being used, and we get the X-ray beam as a narrow band, and it passes through the patient and exposes the film through another vertical slit, or one more collimator is present near the object and the receptor. What is the advantage of this narrow beam is that it gives a minimal exposure to the patient. Then we have a head positioner where we have seen there is a chin rest, a nose biplock, and a forehead rest and lateral head support guides. So this is where you can do a chin rest. This is a biplock. This is a head positioner where it is being placed. And next is your exposure controls, that is the milliamperage and kilovoltage settings are adjusted and varied to accommodate the patient of different sizes. Appropriate exposure settings should be selected typically at the range of 70 to 100 kV and 4 to 12 milliampere. And this is the exposure parameters. If you have 76 kbp and 15 milliampere with an exposure of 15 seconds, the dose of the patient is around 0.103 milliroentgen. Okay. The next is intensifying screens and cassettes that is being used if we are using a conventional radiograph. We'll come to digital image receptors. It is now being used increasingly to make the panoramic images. So we use PSP plates. After exposing the plate, the image is processed by reading the latent image of the PSP plate, yielding the digital image. Other than that, we have a CCD, that is complementary metal oxide semiconductor sensors. So using the digital receptors, it is being the sensor array transmits the electronic signals to the controlling computer, where the image is being displayed on the screen. That is, we can see the images on the computer screen from where we can take a print. Or these digital modalities allows the user to modify the images. Okay, in the computer itself, we can modify the characteristics such as the contrast, the density, or we can measure the areas, we can do magnification, edge enhancement, and color entry. And how is it being stored? The most of the images are capable of exporting, and it is being stored as DICOM files, that is digital imaging and communication in medicine format, or in a variety of standard image formats, such as your TIFF, that is tagged image file format, or joint photography experts group, that is JPEG, allowing easy exchange of your radiographs. So what is the procedure? How are you going to take a panoramic radiography? So first thing is we should explain the procedure to the patient. Then we ask the patient to remove his or her earrings, jewelry, hairpins, spectacles, dentures, and removable orthodontic appliances. And the procedure and the equipment movement is being explained to the patient. We ask the patient to wear a lead apron without a thyroid collar and position the patient. Then the position of the tongue should be explained. It will be touching the palate. Set of exposure factors and adjust the height of the machine to accommodate the patient. Center the lower border of the mandible on the chin rest. We have seen the picture, and is equidistant from each side. So we'll position the patient's head. It is being placed on the headrest, chin rest, sorry, and the patient is asked to bite on the bite block with the front tooth after standing erect, and asked to bite on the plastic block, okay, that we have told. The upper and the lower front tooth region must be placed in an end-to-end position in the groove of the bite block. The mid-sagittal plane should be perpendicular to the floor and aligned with vertical center of the chin rest, and the Frankfurt plane should be parallel to the floor. That is the basic positioning, and this is how a patient will be positioned in case of a panoramic radiograph. We can see the patient is standing erect, the hands are being rested, the patient has kept the chin, see here on the chin rest, we have adjusted the planes, and we have kept the headrest as well. We have asked the patient to bite on the bite block with the anterior tooth. Okay, then we ask the patient to stand still and without moving, and this particular machine, this area will be rotating around the patient, and then we expose the patient. So appropriate exposure setting should be selected, and typically in the range of 170 to 100 kV and 4 to 12 milliampere. So if the patient is unable to stand, we can lower the machine and make the patient sit and do the same setting as well. So what is the importance of accurate patient positioning? So why do we have to do all this, follow all these instructions? The positioning of the patient's head with this type of equipment is critical. It must be positioned accurately so that the teeth lie within the focal trough. So very important point that we have discussed. And parts of the jaws outside the focal trough will be out of focus. So we are going to get a blurred image. So this particular positioning is required so that the entire structure which is necessary falls within the focal trough. Patient's malposition is represented mainly as a distortion in the horizontal plane. Teeth appears too wide, too narrow, or foreshortened or elongated. So we'll come to those errors later. That is, what are the errors that is being caused if the patient is not positioned properly. So basically, for our image to be proper, to be accurate, we position the patient in the way we have to. Okay, so what are the bony landmarks? What are the areas that we can visualize in a particular radiograph, in a particular panoramic radiograph? So this is a pictorial representation of your radiograph as well as a drawn picture of the landmarks that can be seen in maxilla and mandible. So we'll see it in detail. So we can see the mastoid process. So we'll explain it with the help of a diagram. So this particular area, so compare it with the radiograph, panoramic radiograph. This will be your mastoid process, the elongated styloid process, which will appear radio opaque, and your auditory meatus, that is external auditory meatus, which is located in the temporal bone, and it will be seen radiolucent. It will be seen as a radiolucent area. Then you go for your glenoid fossa or the mandibular fossa, which is going to appear over here, and you have your articular eminence, so that is behind your condyle, the lateral pterygoid plates that will be present here, that is distal to your maxillary tuberosity. Then you can see your pterygomaxillary fissure, which again appears as a radiolucent area. And next is your maxillary tuberosity, just behind your maxillary third molar. You will see your infraorbital foramen in this region, just below the orbits, you can see. Orbit, that is a bony socket which contains your eyeball. It can be visualized as a radiolucent area with a radio-opaque, fine radio-opaque border. Then you have here, coming to the other landmarks, you have your incisive canal that will be placed. It will be radiolucent canal, which and there will be incisive foramen, which is again radiolucency that is located in between the roots of your central incisors. Then you have your anterior nasal spine, that is a V-shaped bony radio-opaque area in the intersection of floor of the nasal cavity and the nasal septum. So you have your nasal cavity, which is again a large radiolucent area above the maxillary incisors. So this is your nasal cavity. Next is your nasal septum, a vertical radiopaque portion that divides the nasal cavity. Then is your hard palate. You can see over here your hard palate, which separates the nasal cavity and the oral cavity. The maxillary sinus and the floor of the maxillary sinus. So this particular area, it is being seen in the seen near your maxillary posterior region. So this will be your floor of the maxillary sinus, which is radio opaque, and radiolucent area being your maxillary sinus. Then continuing, we can see the zygomatic process, zygomatic arch, and the zygoma, so which is being marked here. So the zygomatic process, you have your zygomatic arch and your zygoma, which is the continuation. And there's a hamulus that is being present and of course the entire dentition is being visualized. So these are the areas that can be seen in the maxillary region. So comparing it to the radiograph will help in a better understanding. So coming to the mandible, what are the normal structures that is being seen? This is your mandibular condyle. It is a round projection, so we can identify the mandibular condyle, round projection of bone extending from the posterior superior border of the ramus, posterior superior border of the ramus of the mandible, and it articulates with the glenoid fossa that we have seen in the landmark of mandible. So in radiograph, how does it appear? Any bony thing, it appears radiopaque. Then second is your coronoid notch, continuation of your condyle. And we are going to the coronoid process. So this is your condyle, your coronoid process, which comes in this region. The next four is your mandibular foramen. So it will come in this particular region, down, round or ovoid opening in the lingual aspect of the ramus of the mandible, which is again radiolucent. So this is your ramus continuing. This is the ramus, and this will be the body of your mandible. And six, this is this particular small tongue-shaped projection, which is radiopaque. It is known as lingula, and we have a Mendel foramen in between the premolars. That is in this particular region where this canal ends. So in between the premolars is your Mendel foramen, which is again a ovoid round radiolucent area. Then inferior border of the mandible, sorry, mandibular, inferior alveolar nerve, that is your this particular area, your mandibular canal, okay, simply your mandibular canal. Then your Mendel ridge will be located. It is a thick radiopaque band that extends from the mandibular premolar region to the incisal region. So you can see this particular Mendel ridge. Then you can see your Mendel fossa in between the radiolucency. You can see Mendel fossa as a radiolucency in between your premolar, in between your central incisor, mandibular central incisor region. Then you have your lingual foramen just below that, which is surrounded by your genial tubercles, foramen being radiolucent and your genial tubercles being radio-opaque. Then last one is the inferior border of your mandible, that is the lower border of your mandible that is being seen. Then there's something called as your mylohyoid ridge. That is, it is seen here in the mandibular posterior region as a dense radio-opaque band, then extends downwards and forwards from the molar region. Then you have your internal oblique ridge, which is extending posterior to your mandibular third molar, and you have your external oblique ridge that is continuation from your ramus, and angle of the mandible, which is being seen as in this particular region, continuation of your ramus and body. In between, there's your angle. Lastly, it is your entire dentition, mandibular dentition, that is being seen, and you can also see your hyoid bones. And this a U-shaped radio-opaque body that is being seen. So these are the landmarks, normal anatomical landmarks in the maxilla and the mandible that can be visualized. So other than that, what are the other areas that can be seen? It is the air spaces. So first one will be your palatoglossal air space, which is being seen below your soft palate. Okay, and next is your nasopharyngeal airspace, which is being seen posterior to your pharynx and the oral cavity, which is being seen diagonally, and it is continued by the glossopharyngeal airspaces. So nasopharyngeal airspace is a portion of the pharynx that is located posterior to the nasal cavity, and the glossopharyngeal airspace is a portion of the pharynx that is located posterior to your tongue and the oral cavity. So these are the air spaces that can be visualized. So this is your palatoglossal, nasopharyngeal, and continued by glossopharyngeal air spaces. So what are the soft tissue images that can be seen on the panoramic images? First one will be that of tongue. So this will be seen over the mandibular posterior region as a radio-opaque superimposed over the maxillary posterior region. Second one is your soft palate and the vula, which is being seen posterior to your maxillary third molar, that is in your tuberosity region. Next is your lip line that will be seen as a radio-opaque band in the maxillary central incisor region as a radio-opaque band. And last is your ear that will be seen as a radio-opaque area over your styloid process. Okay, so these are the shadows of the soft tissues that can be visualized. So this will be shadows. So these are the areas. Then what is the advantage of using, so these are the landmarks. And coming to the advantage of using a panoramic radiograph, a large area is imaged. So we have seen different pictures of panoramic radiograph by now. So we know that a large area is imaged and all the tissues within the focal trough are displayed on the film, including the anterior teeth, even when the patient is unable to open the mouth. So in case of a trauma where there's a fracture in your TMJ region, condyle region, the patient is unable to open the mouth, this particular procedure can be carried out so that we get to know what has happened and where is the fracture. The image is easy for the patient to understand and therefore it is a useful teaching aid. So if we say that this is the mandible maxilla, the patient understands and if a problem with a particular tooth is being explained. So it is easier for the patient to understand and can be used as a teaching aid. Positioning is relatively simple and minimal expertise is required. The overall view of the jaws allows rapid assessment of any underlying possible unsuspected disease. So, in case of IOPia, we are going to visualize only a particular region. So, since we are seeing the entire region, so if there's some unidentified or undiagnosed pathology, we'll be able to identify. And the view of both the sides of the mandible on the film is useful when assessing fractures and it is comfortable for injured patients. So, we'll see both the sides so we can compare the right side to the left side, the normal side to the abnormal side. The radiation dose is about 1/3 of the dose from a full mouth survey of the intraoral film. Okay, the patient exposure is being reduced. Development of the field limitation techniques with resultant dose reduction. Okay, particularly the patient dose is being reduced. So what are the disadvantages? Of course, there are disadvantages. The tomographic image represent only a section of the patient. Structure or abnormalities not in the focal trough may not be evident. So whichever is outside our focal trough is out of focus and it is being blurred. Soft tissue and air shadows can overlay the required hard tissue structures. So we have seen there are soft tissues and air shadows, so they can come over the required structures. Ghost or artifactual shadows can overlay the structures in focal trough. So we'll come to the artifacts that has been created. So they can also hamper the images and the diagnosis. The tomographic movement, together with the distance between the focal trough and the film, produces distortion and magnification of the final image. Use of indirect action films and intensifying screen results in some loss of image quality if it is conventional. The technique is not suitable for children under 5 years or on some disabled patient because of the length of exposure cycles. So there's a set of instructions that has to be obeyed, so which is not favorable for people like under 5 years and the disabled patients. And procedure is not cost effective compared to IOPRs. It is more expensive. Our panoramic imaging is more expensive and hence it is not cost effective. So what are the common errors in panoramic imaging? So we have seen the techniques, landmarks and all. So do we come across any errors? Of course we come. So first one being is ghost image. So this is a radiographic artifact seen on the panoramic image that is produced when a radio-dense object is penetrated twice by the X-ray beam. So we'll just see some pictures. Before that, we'll just say some characteristic of ghost image. A ghost image resembles its real counterpart and has the same morphology. So if there's a ghost image, it will have the same property as that of your object being exposed, and it is found on the opposite side of the real counterpart. It is usually placed higher than the actual counterpart and it is always larger than the real counterpart. So we'll see a picture. Okay, so this is the image. There's a ghost image that is being formed. Okay, so what were the characteristics? It is being seen on the opposite side. It is distorted. It is above the image that is being formed and it has shifted the side as well. Okay, and it is blurred. It is not as clear as this particular image. So this is a true image of an earring and it has formed a ghost image of the earring appearing on the opposite side of the film. It is enlarged and it is distorted laterally. So this is another ghost image of the neck chain. So if the patient has worn a neck chain, it has come in the apices of the lower anterior teeth. You can see a ghost image that is being distorted. Next is patient positioning error, which has caused the real image, the ghost image of the ramus that has come in the opposite direction. So this particular area is being distorted. The ghost image of spine, the patient is not standing erect. It has come in this particular mandibular anterior region. You can see a double real image of the spine in this particular region. See, so it has come as a radio opaque shadow. Second one, so first one was ghost image, and second one is lead apron artifact. So the patient is wearing a lead apron, and the lead apron artifact appears as a large cone-shaped radio opacity obscuring the night. Patient can wear, but if it is the person positioning is wrong, it can come as a radio opaque area over obscuring the entire image of your panoramic picture. The next is the patient positioning error. So positioning of the lips and the teeth. If the lips are not closed on the bite block, a dark radiolucent shadow obscures on the anterior teeth. The shadow will come. And next is positioning of your Frankfurt plane. So if the patient's chin is positioned too high, or if the patient's chin is tipped up, so what are the things that is going to happen? The hard palate and the floor of the nasal cavity appear superimposed over the roots of the maxillary teeth. The loss of density in the middle of the radiograph, characterized by an hourglass shape. The maxillary incisor appear blurred and magnified, and loss of one or both the condyles at the side of the fillet. A reverse smile line is seen on the radiograph. So that is an important characteristic feature. You can see a reverse smile line. So let us see how the image appears. So we can see it is like a reverse smile line, overlapping of the images of the teeth and an opaque shadow obscuring the roots of the maxillary sinus. Roots of the maxillary teeth and the sinus of the chin is rotated upwards. Okay, you can see that there is some shadow that is happening over your maxillary posterior teeth and the sinus. Okay, and there's a reverse smile line that is being seen, and your anterior teeth is being distorted, and this particular area is has reduced density. So what happens? That was when the patient's chin was placed more up. So what is it when the patient's chin is placed more downwards, or the alar tragus line greater than 5% downwards? The patient's chin is positioned too low, or if it is tipped down. So what are the characteristic features? The mandibular incisors is going to appear blurred, and there's a loss of details in the anterior apical region of the mandible. Okay, there's an exaggerated smile line. So other one was reverse smile line. This is an exaggerated smile line, and the condyles may not be visible. So here you can see that the condyles are missing. Okay, this area, this particular area condyles are missing, and there is an exaggerated smile line that has happened, and the entire area of the mandibular anterior teeth, it is being distorted. So that is happening when the patient's chin is placed more downwards. Next is positioning of the teeth. So we have told and the teeth anterior should be in the bite block, in the indentation of the bite block. Anterior to the focal nerve, the patient head is positioned too far forward. The anterior teeth are not positioned in the groove of the bite block. Okay, the patient is not biting on the indentation of the bite block. What is going to happen? The anterior teeth is going to appear skinny and out of focus. So you can see the anterior teeth is skinny and it is out of focus, and spine is superimposed over the ramus area. So you can see the superimposition as well. Posterior to the focal nerve, the patient's head is positioned too far backwards. So if the patient again, the patient is not biting on the bite block properly, what happens is that the anterior teeth appears fat and out of focus. So before it was the teeth was appearing wider, thinner, but now the teeth is appearing fat and it is out of focus of blurred image. You can see how the teeth appears more fatter. Okay, compared to a normal image, and excessive bursting of the mandible and the spine can be seen. So this entire region, it appears distorted. The anterior teeth appears widened and blurred on the panoramic image when the patient is positioned too far backward on the bite block. So you can see, appreciate it. Positioning of the mid-sagittal plane. So there is another error. If the patient's head is not centered, The ramus and the posterior teeth appears unequally magnified. So you can see this particular region where this condyle is being disappeared. Okay, that is the thing that is happening if the positioning of the mid-sagittal plane is not happening, or the patient's head is being not centered. If the next is positioning of the spine, that is if the patient is not sitting or standing with a straight spine, the cervical spine appears as a pyramid shaped radiopacity in the center of the film and obscures the diagnostic information. So, this is a picture that is showing that there is a superimposition of your spine where the patient is not sitting or standing erect. Then the positioning of the tongue during exposure. The tongue is not fully placed against the roof of the mouth. A dark shadow appears in the maxilla below the palate and apices of the maxillary central. Maxillary incisors are obscured. So, of course, the tongue should be placed over the palate. Otherwise, a shadow is going to appear over the maxillary, over the apices, over the palate or the apices of the maxillary incisors. If there's a distortion, what happens if the patient is moving? So all these were positioning errors. So what happens if the patient is moving when our radiograph is being taken? If the patient is doing a sudden jerky movement in the direction opposite to the movement of the beam, that part of the object may be missing. Okay, that particular area of the patient has moved in which direction, that particular area will be missing in the image. So if the patient moves up or down, there will be indentations in the lower border of the mandible, same like a fracture. Okay, so that is when the patient moves, and there's something called a static electricity. It appears as black lines or dots, often having a tree branch like static marks on the radiograph. It is caused by removing the film from the box or cassettes too quickly, creating a static discharge. So this is in case of conventional panoramic imaging. So all those where in case of your digital imaging where there's an error in patient positioning, or the patient is not standing erect, or our positioning is not correct, or the patient is not biting properly, if the patient has moved, so all these errors can appear, and if it is your conventional, there can be an error of static electricity. So all that we have taken the radiograph, we have seen the errors. How are we going to present this radiograph to the patient? So print of the OPG image is taken after proper evaluation of the image. Okay, the image is being evaluated. If all the areas are seen, okay, the area of interest is being properly visualized. The film is cut to accurate size using a film cutter, and the print is placed in the cover, which contains the demographic details of the patient, that is OP number or ID or OP number, name of the patient, age, date, and referral department. Okay, that is how the image is being presented to the patient. Next is the advancement. Okay, advancement in panoramic radiography, CBCD, that is your three-dimensional imaging, con-beam computed tomography. Based panoramic images are now being used by the clinician for accurate assessment of the structures, mainly in the field of oral surgery and implant dentistry. Okay, it has gained popularity in almost all the fields. So new machines are available with 3D imaging and 2D imaging in the same unit, and this is useful in comparison of both the images, which is helpful in arriving at an accurate clinical diagnosis and proper evaluation of the anatomical structure. So what happens in this particular thing is that you can evaluate the three-dimensional picture and the two-dimensional picture at the same time. So if it is in case of some cyst or tumor or anything, you can do the exact location in all the three dimension with the help of CBCT and the panoramic image construction, panoramic image, and the 3D reconstruction. So that is the advancement. So coming to the conclusion, recognizing normal anatomical structures on panoramic radiograph is challenging because of the complex anatomy that we have seen, complex anatomy of the midface, the superimposition of the various anatomic structures, and the changing position orientation. The diagnostic value of these films has increased considerably if the clinicians are aware of the limitations and apply a systemic approach to the interpretation. So the basic knowledge of the normal anatomical landmarks is very necessary for us to interpret the pathology. The diagnostic value will be further enhanced by the increasing use of digital panoramic radiography with all its inherent advantages of the image manipulation. So with the introduction of 3D imaging, Along with 2D imaging, it has improved to a greater degree. The diagnostic area has improved to a greater degree. So these are the references. Thank you.